My pleasure to welcome you to the first model of this webinar series produced by Biostats and sponsored by Intrauma. In this specific model, we will focus on comprehensive review of the orthopedic examination, including the following learning objectives. So, gain an appreciation of most important steps of the orthopedic examination completed before ever laying your hands on the animal. Understand the key components of a complete orthopedic examination. Appreciate specific maneuvers and diagnostic techniques to aid in the diagnosis of patellar and coxofemoral luxation. But before we start, as usual, as you know, the lecture is composed of 45 minutes, and then you will have, at the end of the lecture, 20 minutes of Q&A. So please keep the questions for the last part of this hour. You have a dedicated question and answer section in the bottom of your screen. It is time for me to introduce our speakers. Welcome Dr. Stephen Jones. And Dr. Stephen Jones is an assistant professor at the Ohio State University College of Veterinary Medicine. He's a diplomat of the American College of Veterinary Surgeons. He has written and published numerous scientific papers and abstracts and lectures and teaches all over the world. His special interests include treatment of cranial cruciate ligament disease, minimally invasive fracture repair, arthroscopy, medical and surgical treatment of the joint disease, and surgical management of angular limb deformity. I'm happy to welcome Dr. Stephen Jones.
Thanks, Franco. Great to be here, and thanks for those of you who are joining me live and those later who will just see the webinar on a playback. Thanks for joining up and supporting us. I want to thank Franco with Intrauma supporting us for these this series of lectures. They produce some very great orthopedic instruments and implants, and if you get a chance, check out their website. They have some really good implants, and I encourage you to show them your support because they're supporting us here. So what I want to talk about here with the orthopedic exam, there are many people out there that are doing orthopedics, maybe on a semi-routine basis, but perhaps aren't still 100% comfortable with all aspects of the orthopedic exam. More commonly, what we see is veterinarians who kind of ignore orthopedic issues and refer it, just don't want to deal with it because they're not comfortable with the orthopedic exam. They're a little bit scared about it. And I really think that the orthopedic exam shouldn't be something to be intimidated by. It's something that we should all practice and do as much as possible, because even if we're not going to, treat that animal or do the surgery, at the very least we should be able to come up with a list of differentials and be able to advise the owner on what we're going to recommend. So for me, when I'm talking about the orthopedic exam, when I'm teaching the orthopedic exam, and I teach it to the students, residents, and I teach it at a number of conferences, I really break it down into 4 parts. And I think all of these combine into the overall orthopedic exam. And if we look at this, we think, okay, history taking, gait examination, neurologic examination, we say none of those are orthopedic exam. Okay, maybe individually, if you look at it, maybe they're not. But I do think that they all contribute to a comprehensive review or a comprehensive orthopedic consultation and examination, because if you just go and look at the dog and don't sort of take those 3 into account, the first 3 into account, we're going to maybe miss something very important. So I think all of these are important components of the orthopedic exam, and I'm going to go through these one by one. So history taking, I think, is the first part of the exam, and sometimes just walking in the room and seeing the dog can help you narrow down your list of differentials. So for example, if I see this Yorkshire Terrier coming in, 8 years old, right hind limb lameness, I'm not thinking hip dysplasia, because they don't tend to get hip dysplasia almost ever. I'm not really thinking elbow dysplasia because it's hind limb. I'm straight away thinking MPL, so patellar luxation, or potentially patellar luxation with a cruciate ligament rupture, or a cruciate ligament rupture by itself. But just seeing the patient, knowing the signalment, so age and breed, can very much help you focus in or get a list of differentials that you think may be what's going on. Of course, once in a while a zebra will run by and you'll get something weird, but in general, common things are common. I would advise you to obviously listen to the owner, but just be a little bit cautious. Sometimes the owners don't know the limb that's affected. They might tell you it's the right front, but they're looking at the dog, and to them it's the limb on the right, but that's the dog's left. And if it's a very subtle disease, owners don't tend to get the down on sound concept. So they see the dog's going down on his left front leg and they say, oh, he's lame on his left front. Well, actually, no, he's lame on his right front. So I just tell you to be cautious with which limb the owner tells you, unless he's very, very lame and he's holding the leg up, then obviously you can trust the owner of which leg the dog is holding up. But if it's a subtle lameness, sometimes they get it wrong. This dog on the right, or this dog in the picture here on the right, is clearly has bandage paralysis and he's holding it up because of a bandage, but most dogs aren't that easy to discern the lameness or which leg, and so just be careful with what the owner tells you. Often they're right, but sometimes they're not. I will ask, is the dog lame at specific times of the day? Because if the dog is lame first thing in the morning after resting all night, and then maybe after a period of rest but warms out of it, I'm thinking something like osteoarthritis. If the owner says the dog is lame pretty much consistently throughout the day, that might be more consistent with something like cranial cruciate ligament rupture, for example. And then if the dog was maybe, say, more lame after activity, then you say it's something more dynamic. Maybe it's a sprain or a strain, or maybe it's something like a fragment in the joint, like for elbow dysplasia, that only becomes aggravated when the dog is active. So certainly you can use that to help you bring in your list of differentials. And then are there any specific activities affected? So an owner telling me my dog really doesn't want to go down the stairs anymore. I'm not sure what's wrong with them, but straight away I'm not thinking hind limb, I'm thinking forelimb, because as they go down the stairs, they're putting more weight on the front legs, and that obviously can exacerbate a painful nidus or focus of pain in the forelimbs, doesn't tend to affect the hind limbs. Conversely, if we have dogs that don't want to get up in the bed anymore, won't jump up into the car, or are slow to go up the stairs, obviously I'm thinking hind limb, and then depending on the age and breed, I'm thinking more maybe hip dysplasia for arthritis, because they don't like to go up things, because they don't like to kind of extend their hips. So getting up onto the bed or climbing into the car really extends the hips, and so if they have sore hips, that tends to be affected. So again, just asking about the activities that are affected can sometimes help you limit your and kind of reduce your list of differentials. Also the duration of lameness, because how did the dog come up lame yesterday? Maybe he just started limping yesterday when he was out in the garden or the backyard. Well, then maybe he's got a thorn in the spot. Maybe it's something very simple. Maybe it is truly just a strain or a sprain that needs some time. But if it's been going on for months, then we know it's probably something a little bit more severe. And has the dog received any medication? That's important for me, because let's say it was a dog with hip dysplasia and the dog had osteoarthritis. Well, I'm not going to do a hip replacement in that dog probably until I know he has failed medical management. So he has to get treated for that condition. And if he does well with the treatment, well then probably not going to put a hip in there. But if he has failed medical management, a total hip replacement might be more likely. However, I want to make sure I know what meds the dog has had. Were they the correct meds? Were they the meds that I would consider appropriate medical therapy, like non-steroidal anti-inflammatories? If so, were they at the correct frequency and dose? Because number one, sometimes dogs are massively overdosed on NSAIDs, and I want to know about that. Or maybe they got NSAIDs and steroids together, which obviously we know should never happen. So then I want to know about that, and then I'd say, okay, well, I'm backing off and giving those meds until I make sure the GI tract is safe. But I really think just finding out what the dog is on, what meds he's on, and is it the correct dose and frequency, and then we can kind of interpret that. If it's the correct frequency and dose and the correct medicine, and the dog's not improving, okay, conservative therapy is not working for this dog. Has the owner tried any rest or activity restrictions? Because, maybe the dog has hip dysplasia and maybe the meds were going to work, but then the dog was running 5 miles a day with the owner. Well, of course it's not going to get better, because the dog is not activity restricted. He's running and jumping and playing. So of course he can't do he's not improving with his clinical signs because he's just, exercising too much. And then lastly, other pertinent medical history like diabetes, Cushing's, heart disease. Do any of these things exist? The owners are very focused on what's going on with the dog right now. The dog is lame on his left hind leg. Well, they kind of ignore the fact that, or maybe neglect to tell you the fact that the dog has, severe heart disease or severe liver disease. And if you don't think to ask that, the owner may not think to tell you. And then you're maybe proceeding to do a surgery on that dog, an anesthetic episode on that dog, when really you shouldn't be getting it. I really encourage you to observe the animal in the room while you're chatting to the owner. Many dogs have been to your hospital before, they've had vaccinations, maybe they had diarrhea, they were vomiting, maybe they stayed overnight because they weren't feeling too well. Dogs don't tend to associate that with a good time, and they're smart enough to remember, dogs and cats. They're smart enough to remember where they are, and they don't like that place, so they tend to get very kind of anxious, and we call that the white coat syndrome, because doctors wearing the white coat and they get a little bit nervous when they see the doctor again. But the calmest the dog is going to be in that room is with the owner. So watch the dog with the owner as you're taking the history. because once you start to try and examine the dog is going to tense up and maybe you lose your opportunity to see a lameness that you would like to see otherwise. So I do my physical orthopedic exam last. I do all of the other things first. Although I said the owners don't always get the limb correct, I do also say ignore the owners at your referral, because maybe they're telling you something that seems really far-fetched, really crazy. I have owners, and sometimes the students will say to me, oh, this owner told me this, and it seems kind of a little bit nuts. I don't think this is what's going on. Well, remember, that owner knows that dog or that cat much better than you or anyone else does. And if they're saying the dog is doing, kicking the leg sideways as it walks, it probably is, because the owners are watching that dog day in and day out. So I just put that in there for people who just tend to kind of make a picture and they want to find out what's going on with the dog, and they have a picture in their mind already of what's going on, and then the owner tells them something that doesn't really fit with that picture. Well, just don't ignore it. Remember, they may be right. They probably are. Okay, so we've gotten our history, signalment and history. Now we're going to talk about our gait examination. And again, I do that before I put my hands on the dog, before I start actually examining the dog. So the gait examination should be done somewhere where there's secure footing and free from distractions. As most of you probably know, most hospitals don't have a good place. The university where I work here, I take the dogs to the basement if I want to get a good examination, but even down there's no perfect place. There's always people around. It's never perfectly quiet like you might like. Sometimes going outside is a good, if you've got like a yard or a parking, a car park or a parking lot where you can take the dog if it's relatively quiet, that can be good as well, because in general the footing is more secure, it's better out there. You don't want slippery floors like tile or linoleum or something like that, because dogs don't tend to walk very well on that, and so you won't see the lameness as well. Try to look at the dog at the walk and the trot. Why do I say that? Because just at the walk, you may not see a mild lameness, but if you get them up to a trot, it may become more obvious. So don't forget to check them at the walk and the trot. Have the assistant, whoever's holding the dog, walk on the non-affected side so you're able to see the side that's affected. And I see this all the time. Students are walking on the side where because they walk the dogs first sometimes, and they're walking on the side where the dog is lame, and I can't see it, and I have to just physically tell them, can you please walk on the other side of the dog? So just remember to do that. And lastly, after you've walked in a straight line forward and back, I like to walk the dogs in sharp circles, maybe up and down off some steps, up and down off a sidewalk or some rough terrain. Why? Because maybe the dog doesn't look that lame going in a straight line because he's not lame, but you challenge him with these abnormal surfaces and kind of terrain, the dog might all of a sudden become a little bit weak, and you might actually see something that you hadn't seen before. So maybe the dog's not lame, maybe the dog has ataxia, which is a neurologic condition. So that's something to watch out for. It is quite common. I get dogs referred to me for lameness, and I examine the dog, and the dog is not actually lame, the dog is ataxic, and it's a neurologic component, which we'll come to next, obviously looking at that. So here's a couple of examples of a dog. This is a dog at the walk. This is in my basement at the university here. And so the dog is walking in a straight line. You can see there are trash cans, there's a doorway. That's not ideal. I'd like to have no doors, no trash cans, nothing that can distract the dog. Because clearly you can see that dog was distracted when he was walking. Now we're going to watch that same dog at the trot. And for those of you who didn't pick up a lameness on the first video, you can see much easier to see at the trot. This dog has a left thoracic limb lameness. How do I know? Because the dog goes down on sound. The dog is putting more weight onto his right thoracic limb, his right forelimb, because he's jumping off his left forelimb. He's trying to spend less time on the left forelimb because it's painful. All of us, or most of us at least, have technology in our pockets like this that we can pull out and do a slow motion video to help us. So sometimes I find that useful. I've done my examination, it's very subtle, I'm not quite sure. I will make a slow-mo video. Now I didn't need it in this case because once the dog started to trot, it was a lot more obvious. But clearly we can see here the dog is spending more time on the right, down on sound. This is a left thoracic limb lameness. So use the technology you have available to you, because sometimes that can help. Okay. And then you got cases like this poor dog had multiple limb disease. Clearly this is a dog that you don't need slow-mo technology because he's going slow enough by himself. So that was the forelimb. We talked about down on sound. What about the hind limb? In my opinion, hind limb lameness is harder to visualize as the dog walks. What we're looking for is a pelvic hike, and the pelvis will hike on the side of the lameness. So what I tell people to do is draw like an imaginary line over the dog's dorsum. Almost like in an equine, if any of you do any equine medicine, sometimes they'll put tape on the horse's back and they'll watch that tape and then you can see it. It's just a visual guide to help you see is one side hiking up more than the other. And so the dog will tend to hike up on the lame side, and that's basically they're jumping off the lame side, so they're hiking up. You don't see the down on sound because of course there's no head to look at for the hind limb. This dog has a right pelvic limb lameness, but it's a little bit more difficult to see. The down on sound is much more obvious for the forelimb lameness. Okay? And then observe for muscle symmetry. So in short-haired dogs, like you're seeing here, pit bull type dogs, any dog that's like short-haired greyhounds, whippets, whatever you want to think of, if you can actually see the muscle bulk, look at it, because the dog is going to be lamer, or the dog is going to have muscle atrophy on the lamer side. So the leg that hasn't been used very much lately because of the lameness is going to lose muscle mass, and especially if it's been going on for a period of time. And that can sort of clue you into saying, okay, if you're not sure, well, the left leg looks thinner than the right leg, that's probably the leg that's affected. Of course, it's possible that the dog has some chronic condition in his left leg that he's coping with, and that's why he's got atrophy on the left leg, and then the right leg is a new phenomenon, and he's actually truly lame on the right side. But it's most likely the side that's going to have the muscle loss is the lame side. So here's a couple examples of gait videos. I'm just going to play them, and I want you to watch them, and then just in your head, start to look at this dog and tell me what you think. I mean, you don't have to tell me, but in your head, make up an idea in your mind of what you think is going on. What leg is the dog lame on? Now, this is a good example of a dog walking on a surface that is not ideal. You can see it's kind of slippery, the dog is slipping. These mats are there for us to do our examination because that kind of linoleum surface that we have here is not very good. But hopefully you're watching that and you're noticing that that dog has bilateral pelvic limb lameness, really short stride in the hind limbs. And so this dog has bilateral cranial cruciate ligament ruptures. Here's another one. Well, watch the dog going down, then watch him coming back, and it's a little corgi. And you'll get an idea just looking at the dog that his legs are not straight, but I think a lot of that is breed related. So down on sound, he's going down on the right thoracic limb, so he's got a left thoracic limb lameness. Here's another one where the lameness is a little bit more obvious. Now, if you clue yourself in, you'll see going down on the left thoracic limb, he's got a right thoracic limb lameness. And this poor dog, I just put it in there, this is a bulldog, and clearly very abnormal thoracic limb lameness bilaterally. He's walking with his head almost on the floor. This poor puppy had bilateral congenital elbow luxations that were not addressed. This is another interesting case. This is a German Shepherd about 4 years of age. And as you watch him walk, you're going to see a very peculiar gait pattern on his left pelvic limb. He's kind of like, watch as he advances the leg forward, all of a sudden it just drops. It drops suddenly. And this is what we call a gracilis myopathy. He had a contracture of his gracilis muscle, which we see predominantly in German Shepherds, and it's kind of being pulled medially. So just another interesting gait pattern. Lastly, I wanted to show you this dog. This is a dog that came into me for lameness. And as I walk this dog in circles, if you watch his hind limbs, he's kind of crossing over. He's not quite sure where those limbs are. He's a little bit unsteady. It's almost like his hind leg or his hind end wants to give out. This dog had hind limb proprioceptive ataxia, and he had a T3 L3 myelopathy. It was very mild, but he had hind limb ataxia. Okay, so now we've done our orthopedic or our gait examination. Now we're finally getting to the orthopedic exam, but there's one step before we get there. However, remember this when it comes to the orthopedic exam, or when it comes to actually putting your hands on the dog. You really have to do this over and over and over to get good at it. And I know that's almost cliche, but I tell my students this all the time. I tell my residents, take your dog at home, feel the dog's elbow, feel the dog's stifle, get an appreciation for what normal feels like, because on the clinic floor, you're going to see a lot of abnormal. If you're not sure what normal feels like, it's kind of hard to differentiate. Just feel the little bones, feel what the olecranon feels like, feel what the epicondyles of the humerus feel like, feel what the patella feels like. All of those things can be very helpful. So when you feel an abnormal dog, you go, okay, this is abnormal. You can do this whatever way you want. It's kind of like doing exploratory laparotomy. You can start at the tail and work forward. You can start at the head and work caudally. You can start proximally in the limb and work distally. Do whatever way you want to do it, but do it the same way every time so you don't miss something. You can also do it with the animal in lateral recumbency or standing. That sometimes depends on the animal's preference or the animal's temperament, because some animals just won't let you put them on their side. So, before you actually start looking for bone pain, I always do a very brief neurologic exam. You've already seen part of that, and that's the gait examination, making sure he doesn't look ataxic. I will assess conscious proprioception in all four limbs. When you're doing that, make sure you support the animal's weight. So here I have my hand underneath this dog's chest. He's on one of these mats so he doesn't slip and fall. And as I lift the leg up and put it down, I'm turning the dorsal aspect of his paw and putting it on the floor. And clearly this dog is correcting it automatically. But it's important that you support the dog's weight so that when he corrects it, or so that when you do it, he's able to correct it. If he was very weak and you didn't support his weight, he might just stand with it like that simply because he doesn't have the strength to correct it. So making sure you support the animal's weight, and that's the forelimb. And you'll see I'm doing the same thing with the hind limb, supporting underneath the pelvis. And again, I'm turning the dorsal aspect of the paw onto the mat and seeing if the dog corrects it. And this is basically telling me, does the dog know in space where his legs are? And he clearly does, and he's looking back at me like, what are you doing, Doc? This is weird. I do that for all four limbs. I'll then put the neck through a full range of motion, and you'll see this dog facing the ceiling, facing the floor, and then I'll go from side to side. Remember, you don't want to do this in a brachycephalic dog like a pug or a Frenchie because you may actually smother the dog or kill the dog. Don't go all the way around. But in normal kind of long-nosed dogs, they can bring the nose all the way around to their side essentially. This is a normal range of motion. Then I'm going to palpate for any spinal hyperesthesia or hypopain. So I'm actually palpating laterally in the neck to see is there any pain on the cervical vertebra, and then I'm going to move down along the thoracolumbar column and see is there any pain as I move down along the thoracolumbar column. So I'm just pushing dorsally on the dorsal spinous processes all the way back. You can see this dog has a very good panniculus reflex here, but I'm going to push on his back all the way caudally to see if I can elicit any pain as I move caudally. Remember, you can see I've got my hand underneath just to support him. Don't push too hard underneath because actually if the dog has abdominal pain for some other reason, you might think it's back pain, but you're actually pushing on the abdomen. So I only have a hand in there to stop the dog from sitting down, but I'm really just pushing firmly, but not very, very hard, just enough to see if there's any pain. One thing I forgot to make a video of when I was making this lecture was a video of the tail height. So the next thing I would do when I was finished that part of the exam is I would go down, I would get the tail, and I would lift it up. And when I do that, I'm trying to assess if there are any lumbosacral pain, so the caudal aspect of his vertebral column, is there any pain down in this area? And if there was, I would follow that up with a rectal exam. In fact, I do a rectal exam in all patients. This is a good time to palpate for muscle atrophy to see is there any loss of muscle. You can do that using a tape measure, and this is called a Gillick, G-U-I-L-I-C-K, Gillick tape measure. And this is very nice because if you think of a tape measure, when you put it around a dog's leg, if you pull tight, it may measure 20. If you put it on loosely, it may measure 30. Well, what's that telling us? This has two little marker balls in there, and when those marker indicators, once you see both of those, that tells you there's enough tension. So you hold it at this black handle and you pull until there's enough tension, and then you can find is the muscle symmetrical or not, right versus left. That works for the hind limb. It doesn't work very well for the forelimbs. For the forelimbs, we'll talk later, but you can actually palpate over the spine of the scapula and see what the muscles feel like right versus left. But because the trunk's in the way in the forelimbs, it's very hard to do muscle circumference. You can do it, but it's a little bit more challenging. So for the orthopedic exam, personally, I like to work from cranial to caudal. So I start with the cranial, the thoracic limbs, and then move caudally to the pelvic limbs. And then in each limb, I start distal to proximal. I never start with the affected limb, if at all possible, because if the dog is very painful on that limb and I go and I grab a sore leg, the dog's in pain, he cries out, now I've lost the cooperation of that patient. So I try to do that last, do the affected limb last. I'll palpate along all the bones. You'll see in this lecture, I'm talking a lot about all of the joints, but don't forget the long bones between those joints, because if you don't palpate on there, you might miss bone pain that might come from panosteitis in a young dog, or maybe a bone tumor in older dogs, or a fungal infection in the bone. Obviously if it was a fracture, you probably know that because the leg would be unstable, but don't forget to palpate along all of the long bones. The goal is find the pain. I usually do my orthopedic exam away from the owner, just simply because I'm going to push that dog pretty hard to get the pain. But it's not wrong to do it in front of the owner. I would just warn them, my job is to find the pain. If I find the pain, I've done my job correctly. But sometimes the owner don't like to see the dog crying out, and sometimes I like to do that away from them, because I like to hear them crying out. It means I've found the source of the discomfort. Like I said, all patients should get a rectal exam, because you may miss a anal sac tumor or lymphadenopathy, lymphadenomegaly in that area. But of course, you can also palpate the lumbosacral joint and make sure there's no pain there. If you're worried about pelvic fractures, you can feel that through a rectal exam as well. Just if you are worried about a pelvic fracture, and there's a different discussion, just be very careful when you're doing the rectal exam, because you can damage and traumatize the rectum if you're not careful. There are lots of ways to remember, little acronyms you can use to remember the things you're looking for when you assess the joints. I use the acronym PRICE: pain, range of motion, instability, crepitus, and effusion. I think it's important to look for those and think about those when you're examining each joint, because if you're not thinking about them, you might miss them. I would say crepitus. People forget to think about them, and then they only think about it when it's very obvious. But if you're actually thinking about it and you're assessing for it, you might find it if it's kind of subtle. Okay, so starting in the forelimb, I start with the phalange, so I work distally to proximally. So what I'll do first is I'll try and assess the digit with the animal standing, because maybe the dog has got a flat toe or a kicked up toe, something like that. And I won't see that if the dog is in lateral recumbency or if I'm holding the leg off the ground. So I try and watch the dog standing first. See if any of the toes look swollen. Just physically, does the toe look swollen? That might give me an indication that's where the problem is. Don't forget to inspect the pads and the webbing between the toes, because it's not uncommon. I mean, usually the cases I get referred to me, it's a little bit more severe, but it's not uncommon where I get a case coming in and the owner thinks the dog has elbow dysplasia, and I examine the dog and he's got a thorn in his pad, and I'm a hero. Because I pull that thorn out, no fancy CTs, everything's very cheap and the owners are happy. But don't miss it. Very easy to miss it if you're not looking for it. I observe and palpate each of the nail beds for any wounds or masses. Nail bed infections are not that uncommon, and that will cause the dog to be very lame. Again, if you don't look for it, you'll miss it. Tumors of the nail bed subungual tumors are quite common. Squamous cell carcinoma and melanoma, and they are nasty tumors. They like to metastasize, so check for them and don't miss them. Then at the digits, there are 3 phalanges, P1, P2, and P3, and I will check all 3 of those and put them through flexion and extension and check them medially and laterally to make sure there's no instability, because there are collateral ligaments along there that can get damaged. And of course, don't forget about the knuckle joint, which is the metacarpal in the forelimb or the metatarsal in the hind limb phalangeal joint. So metacarpal or metatarsal phalangeal joint. And behind them, there are things called sesamoids, and those sesamoids can become fragmented, they can be painful, so you need to palpate back there. That is probably one of the most common diagnoses I make, where owners have come, maybe I've seen a couple of other vets that couldn't find what was wrong with the dog, and I find sesamoid disease, and it's just because it can be hard to find. And if you're not looking for it, you won't find it. So, starting distally, I'll put all of the individual joints through flexion and extension, and then I will check them medially and laterally and make sure there's no instability medially and laterally. Remember I said, check the nail bed, make sure there are no tumors there. And lastly, I'm checking that knuckle joint, the metacarpal phalangeal joint in this case, making sure there's no pain caudally. And I do that for all of the digits. Now moving up to the carpus. Remember, I'm jumping from joint to joint now. You need to palpate all the long bones, including the metacarpals and metatarsals, as you're moving from one joint to the next. Range of motion should be able to flex until the pads touch the caudal aspect of the antebrachium, just like that. And then they should be able to slightly hyperextend, slightly more to 180, about 190. You don't have to measure this, but you want to put them into hyperextension. Now I'm going to apply a medial and lateral strain with the animal and with the carpus and extension. I'm just checking the collateral integrity, so make sure there's no collateral instability of the carpus. And lastly, I'm palpating cranially, right here for effusion. I will usually flex up a little bit and then I'll palpate cranially. Why do I flex up? It opens the antebrachial carpal joint, the main joint. It opens it up a bit more and makes it easier to feel. It also pushes effusion cranially if it's there, so you're more likely to detect it. Effusion to me is like palpating like a water balloon. If you push in a water balloon, it's turgid, but it bounces back at you. Soft tissue swelling is different. You push on it, but it doesn't bounce back, okay, obviously. So that's the difference for me. I almost think of it as pushing on a balloon that's kind of bouncy, a little bit turgid. That tells me it's effusion most likely. Okay, moving up to the elbow. Where are we going to palpate for effusion in the elbow? Well, you're going to be able to feel, or you need to be able to feel the lateral and medial epicondyles of the distal humerus. And then caudally, you got to be able to feel the olecranon. In between those 3 landmarks, there are these little depressions. That's where you're going to feel for effusion. So back in this area here, caudally, you can feel it on your own elbow. Epicondyles, olecranon, there's my olecranon back there, epicondyle the other side, and then in between them, I know it might be hard to see in that little video, but you can feel it in your own elbow. That's where you're feeling that little depression, that little indentation immediately cranial to the olecranon and caudal to the epicondyles. That's where you're palpating for effusion. So olecranon, epicondyles, in between there, right there, that's where I'm feeling for effusion. Don't forget to palpate proximally and palpate the triceps muscle and its insertions, not all bones, because we can get pathology in the triceps muscle and its insertion, that can cause pain. So if you don't palpate for it, you might miss it. When you flex the elbow, range of motion, normal range of motion is that the cranial aspect of the antebrachium should go all the way up to the brachium, all the way up to the humerus like you just saw. And then extension, it goes out to about 165. So not perfectly straight, but about 165. Now I'm going to do supination and pronation. So supination, turn the paw inwards, and then pronation, turn the paw outwards, and put the elbow through a range of motion when I'm doing that. Now I'm going to hyperextend the elbow. All of those things, supination, pronation, hyperextension, what is that doing? All I'm trying to do is see if I can get pain. In a normal dog, if you supinate and do a range of motion, that will not be painful. If you pronate and do a range of motion, that will not be painful. Or if you kind of hyperextend and put you into a little bit more extension to build up past that stopping point, normal dogs can tolerate that and it shouldn't be painful. Whereas dogs that have elbow disease of some kind, that will be painful or may be painful. Why does supination and pronation make them more painful? It's just changing the contact patterns in the joint. It doesn't tell me, oh, by the way, the dog is pain on supination, it's a coronoid process problem. No, it doesn't tell me anything. It just tells me there's elbow pain, and that's all I'm trying to find the pain. If you wanted to test the stability of the collateral ligaments, you can do a test called the Campbell's test. The Campbell's test, you can actually get a goniometer out and measure it, and these are the normal angles for dogs and cats. I almost never do that, probably because collateral ligament injury in the elbow is exceptionally rare, luckily. But I will do the Campbell's test just to try and get pain. So with the Campbell's test, we have the elbow at roughly 90 degrees and the carpus at roughly 90 degrees. And when we have it held at that angle, the 90-90 angle, I then supinate and pronate. And you can actually measure, like I said with the goniometer, how much you're supinating and pronating. This, again, I do to try and see is there pain in the elbow, because it's changing the contact points in the elbow and can cause pain. If you wanted to measure it, you could, but like I said, I almost never have to do that. Very, very rare. Okay, moving up to the shoulder, what are the landmarks we need to be able to palpate? You need to be able to palpate the scapular spine, the acromion, and the greater tubercle. If you look halfway between the acromion and the greater tubercle, that's where the shoulder joint lives. The shoulder joint's in that area. So if you find the acromion, find the greater tubercle, halfway between those 2 points, that's where the shoulder joint is. And you say, well, so what? Everyone knows where the shoulder joint is. Well, actually, not really. I often ask students, can you just point to me where you think the shoulder joint is? And I usually get an answer like that. Somewhere up there, they think that's where the shoulder joint is. Well, actually, if you look at it, over here, we've got the greater tubercle. Over here is where the acromion is. So the shoulder joint's somewhere in between those. The humerus sort of goes up at a 45-degree angle. It goes as much cranial as it does dorsal at a standing angle. So it's very easy to think that the shoulder joint is more proximal than it is. It's quite cranial. It's proximal and cranial. So just remember that. But if you're palpating those landmarks, then you're able to find exactly where the shoulder joint is pretty readily. You won't be able to feel effusion in the shoulder joint or in the hip joint just because of all the muscle around it. So I don't try to feel effusion there. If you can feel effusion in the shoulder joint or the hip joint, that dog has got significant muscle atrophy. So flexion, you should be able to flex so the electron goes to dorsal midline, and you should be able to extend so the humerus goes out almost straight but not fully straight. Some people call it like the Superman pose, like the flying Superman pose. So electron should go up fairly dorsal, and then I put them out as extended as they can go. You'll see it's not quite 180 degrees, but it's close. In large breed dogs, particularly active dogs, working dogs, maybe agility dogs, military dogs, police dogs, dogs that are at high impact activities, shoulder instability, and particularly medial shoulder instability, is a cause of lameness. It's not, I wouldn't say it's common, but it's not uncommon. If we want to assess for medial shoulder instability, we can do the shoulder abduction test. And the shoulder abduction test basically is a measurement to see how far we can abduct the dog's shoulder. It should be done under deep sedation or general anesthesia, because if the dog is painful, even if they're sedated but not deeply sedated, they can fight your abduction angle, and maybe the angle you measure is not the true angle, and maybe there is instability. In general, we say greater than 45 degrees is considered shoulder instability. So this dog was clearly awake. He's actually my own personal dog, and he was awake for this, and he let me do it. But I would not do it with a dog awake like this in reality, because they will fight you if they're painful. So what I'm doing here with my left hand, I'm pushing down on the dog's acromion, the scapula, because I don't want the scapula to move. Remember, the scapula doesn't have a bony connection with the thorax. It's got a synsarcosis, which is basically a soft tissue attachment. So I want to make sure those soft tissues can stretch. I don't want the scapula to move with the humerus. I want to see how does the humerus move relative to the scapula, because that's the shoulder joint. Remember, the distal aspect of the scapula is the glenoid. So I'm pushing down with my left hand in this situation, and I'm lifting up the elbow, lifting up the humerus at the level of the elbow, and I'm moving it away from the dog's chest. I'm doing this with the shoulder in extension. You might not be able to tell that from here, but that's very important. The shoulder needs to be in extension, and then you abduct with the shoulder in extension. Once you do that, you can get a goniometer out, and we're going to measure this angle in here. So if you imagine that's this angle, this acute angle, not the obtuse angle, the acute angle, or you could measure the obtuse angle and subtract that from 180. We're trying to measure the acute angle to see how far does that shoulder abduct, and like I said, greater than 45 is considered abnormal. Another test we can do for the shoulder is a test called the biceps test. And the biceps test, in most people's minds, when they hear that said, oh, we're testing the biceps. And the answer is yes, you are testing the biceps, but you are also testing the shoulder. And what does that mean? It means if we get a positive biceps test, and a positive biceps test means there's pain, that tells me there's shoulder pain. That may be coming from the biceps tendon, but not necessarily. Because we now know if you get a positive biceps test, so we get pain with the biceps test, it may be anything in the shoulder really. So I just use it to try and detect shoulder pain, and if I do, then I follow that with further diagnostics. So how do we do the biceps test? Dog and lateral recumbency usually, or you can do it in standing actually. Flex the shoulder and then extend the elbow. And look, this dog's paw is almost up, it actually is up at dorsal midline. Now I'm going to palpate in this little groove immediately medial to the greater tubercle, and that's the intertubercular groove, also called the bicipital groove. And I'm going to push in there and see if there's any pain. This last part of that test is truly pushing on the biceps. These are two separate tests, actually, both called biceps tests. The first test where I flex the shoulder and then extend the elbow. What is that doing? Well, the biceps tendon runs from here all the way down to the elbow. So if I flex the shoulder, that stretches that tendon. Then if I extend the elbow, it stretches that tendon even further. But again, we're just looking for a pain response. I'm not sure if I have volume on here, but I'm going to turn my volume up and play this. This is a biceps test with the dog in standing. Flex the shoulder and extend the elbow and lift up. So hopefully you can hear that dog was whimpering and crying. I examined this dog thoroughly and couldn't find anything. That was the only thing I found was pain on the biceps test. And this was an older Irish setter, and we ended up finding a nerve sheath tumor. So it told me there was pain in the area of the shoulder. It wasn't very specific for the biceps tendon. So it's just another test you can do to try and find pain around the shoulder area. I won't take questions right now, but if you have any questions at the end, I'm happy to answer them. Or if you want to type them in, I'll get back to them at the very end in the question and answer section. We'll answer them at the end, but I'll just keep moving. Okay, going to the hind limb. We're going to ignore the digits and the metatarsals again, because that's the same as the forelimb. Now we're getting to the tarsus. Landmarks I want you to be able to palpate. Lateral malleolus, which is the distal aspect of the fibula. Medial malleolus, which is kind of the distal medial aspect of the tibia. And then caudal ecronon, the calcaneus. This is very similar to the elbow, because if you can feel those three landmarks, the malleoli, medially and laterally, and the calcaneus, in between those, you're going to find a little indentation. That's where you're going to palpate for effusion in the tarsus. So here we are. Here's the lateral malleolus, calcaneus, and you see that little depression. The medial malleolus obviously on the inside. You can also palpate cranially, like I'm showing you here. Remember, cranially there are extensor tendons in your waist, so you just need to feel around them. Lastly, I'm palpating the Achilles tendon to make sure there's no swelling or pain with the Achilles tendon. If you're palpating cranially for effusion, remember that if those tendons are in your way, sometimes it's a little bit harder to feel it. That's why the caudal portion, just immediately cranial to the calcaneus, is a good place to feel for effusion in the tarsus. So for flexion, we're going to bring the dorsal aspect of the pes, or the foot, where the metatarsals are. They should pretty much go very close, if not all the way up to the tibia cranially. And then extension, like the elbow, it doesn't go out fully into extension, but about 165 if you were going to measure it. So that's a normal flexion, almost all the way up to the dorsal, to the cranial tibia. And then extension, and you'll see here I'm hyperextending, and I'm doing that to see if I can find pain. That won't create or cause pain in a normal dog, but in a dog with disease, that can actually be painful. Lastly, I'm going to check the collateral ligaments of the tarsus. This is different to the carpus. With the carpus, you have you checked it in extension, medially and laterally. In the tarsus, you need to check it in extension and in flexion, because there are 3 collateral ligaments on the medial side, and there are 3 collateral ligaments on the on the medial and lateral side, 3 on each side. Sorry. But if you check them in extension only, which is the easiest way to do it, you may miss an instability in flexion. So these ligaments work differently. Some work in extension, some work in flexion. So we need to check it in extension and flexion. So I'm going to just play this video and let you watch that. So I'm just flexing up a little bit more, and so the reason I'm doing that is to make sure I'm checking the joint in flexion to see that the collateral ligaments in flexion are also intact, and they certainly seem to be. So that's important. If you just check it in extension, you might miss instability in flexion, and that's actually the more important component in flexion. Okay, moving up to the stifle. Palpable landmarks, patella, tibial tuberosity, they're cranially, and then kind of caudally, but also laterally is the fibular head. If you look up from the lateral side, you see that fibular head is quite caudal, but you need to be able to palpate that. And lastly, you're going to be able to palpate the lateral fibula, or more specifically, the caudal aspect of the femur at, immediately caudal to the patella. You might not actually be able to feel the fibula itself through the skin, but you need to be able to feel back caudal to the patella where you fall off the femur here, because these are the landmarks we need to be able to identify when we're doing the cranial draw exam. So range of motion, should be able to flex so the calcaneus goes up to the tuber ischiae, and then we should be able to extend out to roughly 160 degrees. Again, I will hyperextend to see is there any pain with hyperextension. That's something we might find pain if a dog had something like a partial cranial cruciate ligament rupture. As you hyperextend them, you're stretching the cranial cruciate ligament, and that can cause pain. So don't forget to hyperextend to see if there's pain. I will palpate for effusion medially and laterally to the patella tendon, also called the patella ligament. So tibial tuberosity, patella, in between them is patella tendon, and I'm going to palpate either side of that tendon to see is there any of that turgidity that would suggest that there's stifle effusion. Now we're going to see if there's any patella luxation, and the purpose of this seminar series is to look at dogs with common luxations. So we're talking about the hip and then patella in particular. They're the most common luxations that we see in dogs and cats. You really need to push or assess the patella and think about it as you're assessing it, because if you just put a dog's stifle through a range of motion, you may miss a patella luxation. Why? Well, maybe it's a very low-grade luxation and it didn't come out while you were examining it unless you really tried. Or maybe it's a high-grade luxation and it was out the whole time. Well, if it's out, it's kind of harder to tell it's out because it's not moving back in, you're not feeling that clicking or popping. So I really encourage you to find that patella, palpate that patella and see where it is so you know if it's truly in or out. And sometimes it's difficult. I will tell you in those kind of meaty pit bull type dogs that are big, especially if they're a little bit overweight, it can be a little bit hard to palpate, but really try. When I'm palpating for the patella, I will put the stifle through a range of motion while internally or now externally rotating the tibia. Why? Because as I do that, I may cause the patella to pop medially or laterally. So internal rotation for medial patella luxation. And now I'm going to push on the patella. Look, I'm actually using my thumb and I'm pushing on the patella through a range of motion. You might say, well, that's cheating. I'm just trying to get the patella to luxate. Well, yes, I am. I'm actually trying to get the patella to luxate. But in a normal dog, if I internally rotate and push the patella medially, it won't luxate unless there truly is an instability there or if there's patella luxation. Normal dogs, you can do all of these things, it still won't come out. You can palpate in standing or in sort of lateral, so recumbent. In general, when they're standing, they fire the quadriceps a little bit more, and that's a little bit more active. That's probably, sometimes I do it in recumbent and I can't feel it, then I do it in standing and they're kind of fighting and it pops out a bit more because when the quadriceps fire, it pulls the patella out. So sometimes I do both, is what I'm trying to say. Remember, internal or external rotation of the tibia and pushing on the patella can help you find if there's a luxation. We already saw that video. I want to show you this picture. It's from the Brinker, Piermati and Flo orthopedic textbook. With medial luxation, in general, the patella comes out with the stifle extended. Because when the stifle is extended, the patella moves more proximally and it can move out of the groove. There's a shallow groove, it can move out of it proximally and then it can luxate. So in general, if you want to find medial patella luxation, extend the stifle, internally rotate the tibia. I just grab the foot and make the tibia internally rotate, and then push on the patella medially. All of these things can help you find medial patella luxation, particularly like if it's a grade 1 or a grade 2. For lateral luxation, in general, we have to, not always, but in general, it luxates with the stifle partially flexed. So we'll partially flex the stifle, externally rotate the tibia, and then push laterally on the patella and see if we can get to luxate. Why does internal or external rotation matter? Well, when you internally rotate the tibia, for example, we're moving the tibial tuberosity medially, and that can pull on the patella, because connecting the tibial tuberosity to the patella is the patella tendon, so if we internally rotate, that can pull the patella medially. Okay, now we're going to assess the cranial cruciate ligament. There are two major tests we think about when we talk about the cranial cruciate ligament assessment. One is the tibial compression test, and then the second one, which more people are familiar with, is the cranial drawer test. I would encourage you to become familiar with the tibial compression test because one, it's usually less painful on the dog, and two, if you're going to do an osteotomy like a TPLO or a TTA or a CBLO or something like that, or a cranial closing wedge, or lots of different osteotomies for dogs with cranial cruciate ligament rupture, if you're going to do one of those, you need to be able to assess it with tibial compression because cranial draw will still be present after you do the surgery. Tibial compression and thrust should be eliminated. In general, if you're going to do both, which I do, I start with the tibial compression test first because it tends to be less painful on the dog. Palpate medially for butters, which is just soft tissue build up on the medial aspect, scar tissue build up on the medial aspect of the tibia, and you're going to palpate cranially for effusion. So for the tibial compression test, I'm going to stand caudal to the dog. Here I am, caudal to this dog. I'm going to grab the pes from behind. Don't try and grab around the front of the pes and the front of the metatarsus. Grab it from behind. It's just easier because you're going to be flexing the tarsus in just a moment. Here I've got my finger on the patella, and I can see the tibial tuberosity. If it's a very kind of fat, woolly, hairy dog, like a hairy German Shepherd or something, you might need to put your finger on the tibial tuberosity because that's the thing we're assessing to see if the tibial tuberosity moves. So I'll talk you through it. Index finger on the patella or the tibial tuberosity. Other hand grabs the foot or the pes from the caudal position. Now what we're going to do is we're going to keep the stifle roughly at a standing angle, but not letting it flex, and then we're going to flex the tarsus. When you flex the tarsus, the stifle will also want to flex because some of the tendons and muscles that come to the tarsus also cross the stifle. So when they kind of get tightened, that causes a compression across the stifle joint, and the stifle wants to flex. But if we want to do this job correctly, we need to make sure that the stifle doesn't flex. If we do let it flex, we may mistakenly think that there's tibial compression, or we may think there's thrust there, but there's not. So keep the stifle in extension, flex the tarsus. So here we go. We're going to keep the stifle in extension, flex the tarsus, and you see now the tibia is pushing forward. This is called positive tibial thrust. So it's a tibial compression test. If it's positive, there is thrust. Sometimes people call this the thrust test. So if it moves cranially like it does right there, that tells me that the cranial cruciate ligament is ruptured. Remember, don't let the stifle flex. What about the cranial drawer? You've got to find all of those four landmarks that we talked about before. When you're doing the cranial drawer test, you're moving the tibia relative to the femur. So I'm holding the femur relatively stable and moving the tibia cranially to the femur. And you can see here this cranial, the tibia is moving a lot cranially, so that's what we call cranial drawer. I'll play that again. This dog is a cranial cruciate ligament rupture. Nothing else causes this to occur if you've got truly got cranial drawer. Remember, in kind of fat dogs, sometimes you can grab the soft tissues and move the soft tissues, and you think you've got cranial drawer and you don't. So you probably saw at the beginning of this video, but I'll loop this video so you can watch it again. When I'm putting it in the cranial drawer, I'm pushing the soft tissues out of my way with my thumb, so that I'm, as much as possible, trying to grab skin and bone only. I know it's kind of impossible, you have to grab some soft tissues, but push it out of the way. This was a relatively thin dog, but if you had kind of a fat, hairy dog, just remove as much of that soft tissue out of your way as possible. Gives you more of an idea that you're grabbing skin, grabbing bone, and you're moving bone. It's not tricking you into believing there's cranial drawer when you're only moving soft tissues. Okay, moving up to the hip. Range of motion, the stifle should be pretty much able to go out parallel with the ilium. Remember, the ilium is not parallel with the vertebral column, it's slightly tilted distally. And then it should be able to extend all the way out to parallel with the ilium, and then when you flex it, stifle should go all the way up to pretty much the top of the ilium, which is dorsal midline. Another maneuver that people don't tend to do very often is abducting the stifle, or abducting the hip and rotating the hip. So abducting, I'm just keeping the stifle at a natural standing angle, I'll play that again, and just lifting it away from the body. It should go out about 90 degrees. And then we can do rotation. We can actually rotate the hip. So I'm going to externally rotate the hip here in this video. And what we're doing is checking the hip through a full range of motion. This is normal motion of the hip joint. So why do I do that? You might say flexion and extension, that's fine. Well, some dogs that have lower back pain, like let's say lumbosacral disease, or dogs that have iliopsoas muscle problems, if you extend the hip, that will cause pain. And if we're not careful, we might misinterpret that pain as hip problems. Well, actually, if we then go and put the hip through a range of motion with abduction and rotation and there's no pain, well, then I'm thinking, okay, the hip actually is probably fine. It's more likely coming from one of those other two things or something else. Whereas if the dog was painful on hip extension, it truly was its hip, and then you went and externally rotated and abducted the hip and he was also painful and I could feel crepitus, then I'm more confident in saying I think it's the hip that is the seat of this discomfort and pain. So what are the landmarks we need to be able to feel with the hip? Craniodorsal ilium is 1, the greater trochanter is 2, and the tuber ischiatic, the ischiatic tuber ischiatic, is 3. Look at the orientation of these relative to each other. The ischial-iliac axis is more proximal to the greater trochanter, so it makes a triangle with the greater trochanter distal to the ischial-iliac axis. This becomes especially important when we're talking about hip luxation, which is something that we're going to talk about in the next lecture in this series on Friday. When a hip luxates, in the majority of the time, it will go cranially and dorsally in about 75% of the cases. If it goes cranially and dorsally, that triangle will be inverted. So the greater trochanter may be at the level of the ischial-iliac axis or sometimes even above it. So it may be a straight line or it may be an inverted triangle. If that is the case, you can tell whenever taking x-rays that hip is luxated. Okay? So what are we looking for when we look for abnormal disease in the hip or even a hip luxation? Pain and crepitus on palpation. If the hip is out, we should see an increase in distance, especially if it's a craniodorsal luxation, an increase in distance between the greater trochanter and ischiatic tuberosity, and you compare that to the other side. So let's just say we measure that distance y on the left side, which is the normal side, for example, and that measures 3 centimeters, again, for example. And then we measure it on the affected side, it will be longer. So x is the distance on the luxated side, that distance will be longer. So we could actually measure those if we wanted to, and we could say, okay, there's an increased distance, a palpably increased distance between the tuber ischii and the greater trochanter, this hip is probably luxated. Another test we can do, and this is specifically looking for hip luxation, is the thumb test. So with the thumb test, we put our thumb right here, right between the greater trochanter and the tuber ischii. And there's like a little indentation, you'll feel it on the dog on the outside. Put your thumb in there, and then externally rotate the hip. As you externally rotate the hip, that actually should push your thumb out of that indentation, so your thumb actually gets displaced. If the hip is luxated, when you externally rotate the hip, your thumb doesn't get displaced because the hip is way up here cranially, it's out of the way, so it's not going to move your thumb, it's not going to squeeze the tissues and push your thumb out. So that's a thumb test which again can help you determine that the hip is luxated. In general, the limb will be shorter in a dog with a dorsal hip luxation, and conversely will be longer in a dog with a ventral hip luxation. I will tell you a longer limb is harder to visualize than a shorter limb. Okay, moving away from hip luxation, what about dogs with hip instability, usually coming from hip dysplasia? There are a couple of tests we can do, specific tests that we can do to test for that. One is the Ortolani test. This is where we have a palpable or audible, sometimes we can hear it, click, when the subluxated hip luxates or reduces back into the acetabulum. A positive Ortolani tells us there is hip laxity, and that usually comes from hip dysplasia. So how do we do it? The dog needs to be deeply sedated under general anesthesia, otherwise he'll fight it. And even if it is unstable, he might not get a positive Ortolani because he's fighting it. So make sure the dog is sedated or under deep sedation or anesthesia. Lateral recumbency. The operator stands behind the patient, like you see here. One hand is placed dorsal to the pelvis. The other hand grips the up leg at the stifle. Keep the stifle flexed roughly 90 degrees and keep the femur perpendicular to the dog's vertebral column. So roughly at 90 degrees for each of these. But we're grabbing the up leg at the stifle. Next, what we're going to do, ignore this picture for a moment. The first thing I'm going to do is I'm going to bring the stifle. Imagine my elbow in this video is my stifle. I'm going to bring the stifle, I'm going to adduct to bring it towards the table. And in doing so, I'm kind of letting the femoral head clear the acetabulum. Okay, so we're doing this maneuver first. Then we're going to push on the stifle, which is down here, we're going to push it dorsally, and that can cause the femoral head to subluxate out of the acetabulum. And we're going to continue to push, and as we do so, we lift the stifle up. So we abduct the stifle like you see in this picture, and eventually that hip just clicks back into the stifle, into the acetabulum. So lift the stifle up until eventually you feel it click. That's a positive Ortolani. In a normal dog, you can do this all you want, you can push all you want, the hip doesn't subluxate. But if we've got instability from hip dysplasia, the hip will come out, and if we keep pushing and then we lift the stifle up, the femoral head will kind of fall back down into the acetabulum. Positive test will, if you get that click or clunk, that tells you it's a positive test. So Let's look. A colleague of mine, Caleb Hudson, who we teach a lot together, gave me this video. This is a dog that was going to surgery for this problem, so he's all shaved, but he's under anesthesia, and this is a very nice video demonstrating that. So push, 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 and eventually you can actually see it in this dog. You won't always see it in most dogs because they've got hair, and this dog is shaved, but you will be able to feel it. And he's using his thumb here to help him feel it. So push, 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 and eventually it clicks back in. That's a positive ortolani test. You may have heard of Bardens test. I'm just telling you about this, but you don't need to worry about it. I only do the ortolani. I don't typically do the Bardens. It's just another test to test for hip instability. It doesn't tell me any more or any less than an ortolani test if it's positive. But an ortolani test is easier to do. It's more repeatable, so I just do the ortolani test. I put this in here for completeness because some people may have heard about it, may be wondering about it. The Bardens test, again, under anesthesia or deep sedation, patient is in lateral recumbency, affected leg is up. Operator stands behind the patient, grabs the femur from cranial to caudal, and just lifts up on it. Just literally lifts up on the femur. As you lift up on the femur, you got a thumb on the greater trochanter, feeling to see does that greater trochanter shift laterally. If it does, that tells you the femur is lifting up, and that is abnormal. So again, this was Dr. Hudson's video on the same patient. He's lifting up, and you can see as he lifts up, the greater trochanter is popping out of the is popping laterally, so the femoral head is coming up out of the acetabulum. That's hip instability. That's a positive Bardens test. Remember, there are some limitations to this test. One, a negative test does not rule out hip dysplasia. Why? Because maybe the dog has an irreducible luxation. Maybe it's so bad that the hip is out. Well, then we're not going to get it to reduce, for example, with an ortolani, and it may not even move with Bardens. So that's one. Two, if the acetabulum is very shallow or infilled, because with hip dysplasia over time it will infill with bone, there's nowhere for it to go, so it's not going to move. So basically you're not going to get, for example, specifically with the ortolani, it's not going to click back into the cup because there's no cup there. The cup is kind of been filled in, now it's a saucer. There may be capsular fibrosis, so more advanced cases you get lots of scar tissue and fibrosis around it, so we don't get any movement even though it's dysplastic. Or maybe you have insufficient force. If you've got a very, very big dog and you're not pushing hard enough with the ortolani, or you're not lifting hard enough with the Bardens, it may not come out. And that may be because, and then lastly, if you have insufficient chemical restraint. So if the dog is not under deep sedation or general anesthesia, they can fight you. So maybe the instability is there, but you're not able to get it because the dog's so tense, he's fighting you with all his muscles and it's not moving. Okay, we're almost done. Job number one is localize the pain. History taking is a very important component of the orthopedic exam, in my opinion. I encourage you to watch dogs time and time again. I am still getting better at it, and I've been doing it for the last 10 or 12 years of my career. It's not something you'll become proficient at day one. You just need to keep training yourself to watch dogs and you'll pick up subtle irregularities in gait. Try and perform the orthopedic exam in a repetitive manner so you don't miss something. And then after you've done that, chase the pain with radiographs. Or maybe a CT scan, or maybe you think it's a neurologic problem, so an MRI, or you think it's a joint problem, maybe there's an infection in there, you might do a joint tap and orthocentesis. Some people might even do a joint block, so blocking the joint out with local anesthetic. It's something that we do more commonly in large animal and farm animal and equine. We don't do it very often in small animals simply because local anesthetics in the joint are not the friendliest on the cartilage. But it's another diagnostic technique. If all else fails, you can put some local anesthetic into the joint and see if you numb out the pain. If the lameness goes away, well then that tells you the pain was in the joint. So thank you all for your time. I know that was a lot of stuff thrown at you, but I'm happy to answer any questions. And if you ever formulate more questions in the future, I'm happy to answer them by email. I did not put my email on here, but it is Jones, Jones, Jones.5609 @OS